Perfect. Perfect. So basically, as you know, I'm the medical director and physician here at Advanced Fertility Center of Texas, and the reality is we're always trying to bring the latest and most advanced therapy to our center to kind of help our patient do something a little different than regular conventional IVF or conventional intrauterine insemination, try to help them reach their goal faster without the heartache. Next slide.
Sorry, I don't have a control on it. Just a second.
Dr. Farzanek, this is the stress that we both wanted to avoid, giving you the control over our presentation.
Yeah, I don't know for what reason I don't have the control. Maybe you have a control, Dr. Allon?
I don't have the presentation. I wonder, maybe I could perhaps do it here. Can you see me now?
Dr. Allon, do you have your presentation on your laptop right now so you can share the screen?
I don't know how to share the screen now.
On the bottom panel, you have like this green arrow share.
Okay, let me.
Do you see it?
Yeah. No, I don't think I can know how to share it. No. You cannot turn the presentation on. Maybe I can. Oh, maybe now.
Yes, we
Yeah,
see.
let's do this. Okay, perfect. All right, so I'll go. So basically, I'm going to review a few things again. So PRP really helps us get platelets in a small amount of blood volume, like 4 to 5 ml. The beauty of PRP is that it's been used in other branches like orthopedics and plastics for a few years, and we kind of learned from them that, okay, nothing really bad is published in their data and their patient profile. Hopefully, we can use it in our patient population. And so to review again, PRP really stimulates the growth factors, those are the factors that are in the ovary, and it kind of helps heal some of the inflammation that we think a lot of infertility may be due to inflammation, and actually kind of help regenerate the tissue around those follicles. So I kind of wanted to just go basically into the anatomy of the ovary. This is an ovary where a follicle that starts to grow and ovulate takes about 90 days. So in a woman ovulates, this follicle actually grew 90 days earlier. Having known this fact kind of helps us improve whatever, being it health-wise, acupuncture, PRP. We try to do all the maneuvers that we can so that way when we get the follicles out, it will be in the best shape. And so I wanted to kind of review a little bit about entomolern hormone. Entomolern hormone is a hormone that's made by the cells that surround the egg. It's called the granulosa cell. So it helps us. It's a blood test that we use, and it kind of helps us know what the patient's ovarian reserve. How do we assess her fertility? Does she have a lot of eggs? Does she have few eggs? Of course, if she have very few eggs, that's the red light for us, and we kind of try to do whatever we can to help her conceive. The reality is, as women have less eggs, it makes it harder for us to find that perfect egg that will make a human being. And that's the unfortunate thing that we face day to day. And this hormone value that we check on as soon as we see in our first visit, we check entomolern hormone in the blood. And as you can see from this graph, the optimal age is around 25, and then every 5 years to a few years, that hormone level goes down. And unfortunately, women lose approximately 1,000 eggs each month. And so the the problem that we always face is that as they lose more eggs, they also have higher risk of abnormalities in their the remaining eggs. So like at age 35, the risk of Down syndrome is 1 in 350. At 40, it's 1 in 100. So we kind of face a double-edged sword. We have fewer eggs, and the eggs that are there also have more abnormalities. So it makes it that much difficult to find that perfect egg that will make a healthy child. And so when we measure AMH, it kind of helps us know how many eggs, what is her ovarian reserve at that date that we measure it. The higher that number, the less stressful it is. And so like women who have lots of eggs, like PCOS, will have higher number than 5. Women who have low ovarian reserve will see that number like being around 1 or less than 1. The higher the level of AMH, the better they respond to our fertility treatment like IVF and so forth. And it's for sure definitely easier for them to conceive. And as both Dr. Traliga Farzana said, that PRP really helps us hopefully get a few more eggs by nourishing waking up the stem cells in the ovary to try to develop that egg so it could be released. And then by nourishing the environment around the egg, by growing the follicles, we hopefully get that early stage follicle was going to be released to release a little bit earlier and more mature. And the unfortunate thing is that women we see women now later and later at age that I see my patients. Obviously, they have careers to work on. They have other plans in their life, house, husband, and the family planning now is coming later and later. And so we're now seeing more and more patients at a later age. As we see them at a later age, they have low ovarian reserve. And those are the patients that are going to benefit from PRP. And one of the few studies showed that PRP actually can change some of the genetic expression in that ovary and allows those follicles that are dormant to wake up and be released. And also, as Dr. Tralake showed, we think that by doing PRP, we'll get better embryos. So if you get better embryo quality, you have a better chance to get the patients pregnant. And in some of our patients, we did PRP on them, and then approximately 70% of them, we saw that they got pregnant on their own, which is exciting because we're getting them ready. We're doing all the training and the ultrasounds and the blood work, and lo and behold, we do PRP, and then they're pregnant on their own. Well, it's exciting. So it's a testament to the value of this therapy. And the reality is that the younger women have lower AMHs, they have lower follicle stimulating hormone, which also increases with age. And so obviously they'll be the better ones to benefit from this treatment. We'll go back one more, sorry. One more slide. So we think that when we do PRP, we have less cancellation of our treatment with IVF. So hopefully we can get them to grow their follicles, grow their eggs, make embryos, and then have them do embryo transfer and conception. Next slide. Yeah. So there's one study I was kind of wanted to go over, just like Dr. Tralik mentioned. They took patients that have previously done in vitro fertilization and then did PRP on them. And I think some of the patient went under at least maybe 2 or 3 previous IVF cycle, and they failed. And so they decided to do PRP on them. And it's a combination of several centers. And they found that PRP decreased the chance of a woman miscarrying, which is the greatest thing that we can, because you don't want to put an embryo, get a patient pregnant, and then after all that, she ends up with a miscarriage, which is really devastating. And at the same time, they found that PRP actually doubled their chance of getting a live birth when they did IVF treatment. So that was really reassuring and exciting at the time. Next slide. So PRP stimulates the growth factor, as was mentioned before, particularly VEGF kind of increase the blood flow to the uterus. So when it increases the blood flow to the uterus, we hope that increase the uterine lining. And it's important for us to increase your lining because if the lining is very thin and we have great embryos, we had a hard time figuring out what are we going to do with this patient, because if we put the embryo in, the lining is thin, they're not going to get pregnant. So we try to find out whatever we can to improve the lining. We use, things from Viagra to acupuncture. A lot of stuff really doesn't work, but PRP is really something that now we're using that's really made a big change for us. And it's exciting because we're always trying to find whatever we can to improve our outcome. And one of the growth factors, it's called TGF beta. So it increased the growth of the cells in the uterine lining so that way we can have second layer. And immune modulation, with the nice part about this is that when you suppress the immune system, you have a better chance that that embryo will actually grow and implant. And a lot of our patients who had previously failed IVF, failed implantation, the PRP will be extremely helpful because it gives us just one more tool to move forward and to give them more hope. Next slide, please. And this slide, I kind of showed just a little bit about what a normal uterus here and a uterus that's called Asherman syndrome. Asherman syndrome is a uterus that has scars inside. And it's very, very frustrating because some of those patients will have previous miscarriages and they had a lot of scraping or surgery done to the uterus, and it kind of gets scarred inside. And those are very difficult patients because once the uterus is scarred inside, you could go in with a camera, try to release the scars, but the lining still stays small and the scars recur. So it's an ongoing battle. And PRP kind of made a difference in those type of patients that we didn't have any treatment before. Next slide, please. And so we have seen that if you use the PRP at least approximately 48 hours prior to placing the embryos, you get a higher chance of getting the woman pregnant. And by altering the immune response of the patient, that embryo can actually invade inside the mom's lining and implant. And as I was saying before, the Asherman syndrome, where they have uterine scars, we use the PRP is extremely useful because even if we use it twice and then do another hysteroscopy, we have seen that it's definitely helpful. It gives us one more tool to combat these uterine pathologies, and particularly patients that have what we call chronic endometritis. So you put the camera in the uterus and it's all inflamed and it's all red, and you try to get rid of I pick at it and I get some of the inflammation out. It still can recur. We don't really know for a variety of other reasons. And so PRP in those patients are kind of helped kind of nourish the lining, decrease the autoimmunity that's there, decrease the inflammation there, and hopefully have a better outcome. Next slide, please. And it's interesting enough that the platelets themselves have receptors to the hormone estrogen, and they are affected by two of the hormones that are secreted in the brain. Follicle stimulating hormone, luteinizing hormone, are released in the brain and they stimulate estrogen, and so it does affect the platelets that are growing. And so there's a interconnection between the hormones and platelets in PRP. And they do fluctuate through the menstrual cycle. We find that they're really high after ovulation, before the menstrual cycle starts. The PRP concentration is higher than in the first part of the cycle, right after the cycle and before ovulation. So right post ovulation in the second half, what we call the secretory phase, that's when the platelets are at the highest concentration. And not to underscore the biggest issue that we have, the platelets are affected by diet and lifestyle. And as you know, our population has changed, our diet has changed, our habits have changed. So we see many patients that have what we call higher BMI, and we struggle because we even have this morning. I had a hard time finding an ovary only because of higher BMI, and they're very difficult patients. And so one of the things that we have a wellness center here that we're trying to help them kind of lose a little bit of weight if they lost 5 to 10% of their weight before we try to start our treatment. It's very helpful. Not only do they have better response to medication, they have better IVF results, but they respond better to PRP treatment. So it's kind of everything kind of folds together that if you can have a better, healthier lifestyle, better weight, you'll have better results and better response to the treatment that we give them. Next slide. And so, as we mentioned before, and unfortunately, patients who are with higher BMI, their platelets are much decreased. And the nice part about PRP is that if you do PRP today, you can come back 2-3 months later and see the benefits. And some studies have showed that it even can last up to 6 months. So some of our patients, they start treatment and they do other things. They started testing, do other things, and come back. And so if they start with PRP and then maybe say, well, I don't want to do IVF the next month or the following month, giving them this leeway of a few months is very, very helpful for us. And things like non-steroidal, like Advil or Motrin or blood thinners, unfortunately cannot be used around the time that we do the PRP. And also caffeine, like, I drink, like 4 cups a day of coffee. It actually it constricts the blood supply. So that way it decreases the healing effect of the PRP. Next slide. And as we talked about before, it's been used in other medical entities like orthopedics. So its safety has been pretty much established in other medical practices. And so we feel good that the risk of infection is extremely rare. And then the way we administer PRP is the same as the way I do in vitro fertilization. We draw her blood, and then the patient is asleep under very small amount of anesthesia through the intravenous fashion. And we just go through the vagina with a needle. It literally takes us 20 minutes. We inject the PRP just like we do in vitro fertilization, except instead of taking the eggs out, we inject the PRP into each ovary. And then the way we do PRP to the uterus is the same as taking a catheter and putting it right through the cervical canal inside the cavity, just like we do with what we do when we do IUI or intrauterine insemination. So those are conventional things that we do every day. And so doing the PRP is fairly safe for us because we've done it for so many years without any complications. Next slide. So I was trying to go over some cases that we have with our patients. And the first patient here, she came to us from another clinic. She did 3 IVF cycles, and the problem for us is they come in with this much notes, and I have to go and shift to figure out what was going on, what was wrong, how come they did IVF, she didn't get pregnant, and she had 65 eggs from those cycles, but only 3 embryos out of all 65 eggs, which is extremely rare. And next slide. And so here, we did PRP on her twice in approximately 1 month. We got 7 eggs. I didn't want to get 65 eggs because then I wouldn't know what to do with 65 eggs. So we got 7 eggs out of her, and 3 out of 7 we did genetic testing. They were normal. And then I think 3 out of 7 were not normal. So we repeated the retrieval, and then we found some good embryos. And we did PRP also to the uterine cavity because I was worried that maybe it's not just her eggs, maybe it's the uterus. So I wanted to cover both places. And so we did PRP to the uterus with our protocol, and twice, 1 week apart. And then 10 days later, we transferred a single embryo in the next slide, and she conceived. And so it's a tough case because nobody really likes to take, those are very, very complicated patients, particularly when they have so many failure, not only the physical and the psychological impact. And then you have to pick up the pieces and say, okay, let's just try this one more thing, then hopefully it will work. And it did, and it's exciting. It's definitely an accomplishment. Next patient. This patient is also a very difficult patient. She's for 50-year-olds, and what happened as we have older patients, and particularly in 50, 51, and 52, and incidentally, we don't do any patients past 52, is that the blood supply and the contractility of the uterus changes with age, unfortunately. And so in this particular patients, we struggle because we're trying to put embryos in her, and she continues to have fluid in the uterus. And that's frustrating because you don't know what to do. Is this fluid coming from the tube, the cervical canal? It's frustrating. We didn't really have we didn't really know what to do. So she had previous cesarean section in the past. We thought, well, maybe it's the surgery that she had. And she had a donor cycle in another clinic, but she miscarried at 10 weeks. And in our clinic, go next slide. And we took a sample of her fluid and we send it off. We are working with LSU, and we've discovered that she has some protein that are associated with her tube. So we kind of figure, okay, well, maybe this fluid is coming from her tube. And so I took her to surgery. We did laparoscopy. I tied her tubes. It took me half an hour. And then we went back and did PRP to her uterus again, just to kind of make sure that we cover our bases, and then twice. And then we did an embryo transfer 10 days later, and next slide, and she did conceive. And that's like one of the most exciting patients, because not only they're hard to begin with, but they have so many failures. You try to think outside the box. What can we do to make things better? And it did work, thank God. So next slide. This case, again, she had low ovarian reserve. So you see the AMH is 1.29, and normally in a 36-year-old, you like to see it between 2 to 4. So the higher the number, the more eggs they have. And we did IVF on her, and unfortunately the embryo just did not grow and didn't reach the blastocyst stage, day 5. Next, and so in her case, we did PRP to her ovaries, and then waited 3 months and did another IVF on her, and this time she had 2 embryos, which did develop to day 5, but unfortunately we checked them genetically and they were abnormal, so we couldn't use them. So now the husband is looking to have a urology consult, because on our point, it's kind of frustrating. What do we do next? We can get embryos, and now the embryos are abnormal. So what else can we do? And the patient's trying to think, what else can they do to improve themselves? So this is where we are with her. Next slide. In this case, this patient is 33-year-old, but her ovarian reserve is extremely low. It's 0.06. So think of it as, if normal is between 2 to 4, if you have an ovarian reserve at a young woman at 0.06, it's extremely low. And those are the toughest patients, because she also had 1 ovary, but even if you double this number, it's still not going to be very high. And in her case, next one, we did IVF. We couldn't get eggs, and then we had another IVF, had 1 embryo, and then we did PRP to both to this 1 ovary, and then now she was trying to get ready for another IVF cycle, and then she conceived on her own, which is incredible, because one of the things that we think we're doing is that when we put the needle in the ovary, we're kind of waking up some of the old cells, some of the cells that are there. It helps kind of increase the blood supply, decrease inflammation, nourish those other dormant follicles. So maybe this is what we're doing with PRP, on top of the fact that it has beneficial effect of tissue regeneration, decrease inflammation, and everything else. Next slide, please. This patient also she's 38 years old. She has what we call a borderline ovarian reserve, 1.43. Next slide. She went on IVF treatment. We had no embryos. And then we did PRP on her ovaries and repeated the IVF 6 weeks later. And we end up getting 5 normal genetically tested embryo, which is incredible. Because in many of our patients, where they have no embryos, they're like less likely to succeed the next time. But it's exciting that we were able to totally make a 360 on her and have good embryos, good genetically tested embryo, and she conceived with them. Next slide. And this last case, she's 41-year-old, again, secondary fertility. She had, I think, a child with a previous husband, but many, many years ago, and her egg count, ovarian reserve is extremely low, is 0.01, so it's extremely low. And so, again, this is a struggle because not only she has very few eggs, the fact that she's 41 also is more stressful because the eggs that are there could be also abnormal. Next slide. And then on her, we also did PRP into the ovaries 3 weeks apart. And we could only do it to one ovary. We couldn't get to the other ovary, and now she has an ongoing pregnancy. So basically, this is it. Again, like as we mentioned before, we don't have any standardization as to how many cells are we putting with each sample, how much volume do we use. We normally use about 5 to 6 ml. So we put like 3 to 4 cc's in each ovary. We don't put a huge volume. And so again, as Dr. Trelick was saying, I get calls from Austin and other places in trying to do PRP, but if they don't have a good, at least a decent anti-Mullerian hormone number, or they're in their late 40s, where we have to unfortunately refuse them. And we're still working on with MSite and with some of the centrifugation and the counting of the number of cells. And then we think that we could definitely optimize the PRP if we give it about 48 hours before embryo transfer. Thanks. I think this is it. So hopefully I wasn't that boring.
That's great. It's one of your PRP babies. Is that right?
Yes, that's it. It's one of our PRP baby, yes.
Awesome.